Good afternoon and happy Valentine's, everyone. My name is Eleni Anzelatis. I'm from Suburban Hospital's Community Health and Wellness Department. Thank you for joining us today. Today, we are going to take pause and learn or relearn about how to prevent having a heart attack. Today, we have Dr. Greg Kumkumian from Johns Hopkins Community Physicians Heart Care, as well as Meghan Harp from Suburban Hospital's Cardiac Rehab Department. And we're going to talk about how to prevent a heart attack. What are the signs, symptoms, how to best prevent it through diet, exercise, and we'll get started. As you can tell, today's presentation is being recorded, and we will make it available at the end in the coming days, at the end of the week. Also, if you do have a question, which we hope you do, please put the questions in the Q&A box on the bottom of the screen. And most importantly, we would love to hear your feedback from the presentation. And I will be sending a link to our evaluation. And then when you close today's presentation, you will also have an opportunity to complete the evaluation. We will get started with Dr. Kumkumian. And thank you again both for being here this afternoon.
Thank you very much. Thanks for inviting me. I look forward to talking about my favorite topic, coronary atherosclerotic heart disease. As my mentor at University of Maryland Hospital during my fellowship said, it's more exciting in most ways to prevent heart disease than it is to treat it when it occurs. But we'll talk a little bit about both today. I'm going to start off with a case presentation because I think it illustrates most of the topics that we'll talk about. Just about 2 weeks ago, a 50-year-old gentleman who had no history of heart disease presented to the emergency room on the advice of his internist. He had been having some mild on and off, what we call stuttering chest pain, went to see his internist, who was concerned about the symptoms and also some minor EKG changes. He sent him by EMS to the emergency room at Suburban Hospital. Of note, the gentleman was active, mildly overweight, but was training actually for a half marathon and had just run 8 miles a few days earlier without problems. His chest pain was described as a mid pain in the middle of the chest, radiating to both arms. And the discomfort had started the morning that he came to the hospital and kind of accelerated quickly. He felt like, in addition to the pain, he had some indigestion. In background of the patient, he had had an evaluation many, many years ago because of a family history. In his 30s, he had what's called a coronary calcium CT scan. You may have heard of this. It's a very quick CAT scan without contrast dye that measures calcium of the coronary arteries. Calcium can build up in the coronary arteries when plaque builds up. It's not dietary calcium, but it's calcium that builds up from plaque. And he had had a calcium score. The number was relatively low, but as a percentile, because of his age at the time, it was a very high number as by percentile. He had a history of elevated lipids, dyslipidemia or hypercholesterolemia, but had been intolerant to statins, so was not on treatment. And he had a family history. His paternal grandfather had a cardiac arrest right around the age of 50, the same age that he was when he presented to the emergency room. He did not, however, have diabetes or high blood pressure. He was not a smoker. And he was active, although his BMI was 32, so you would describe him as being overweight or mildly obese. But he was an athletic build, so it really, he was in generally pretty good shape. When he came to the emergency room, initially there were some subtle EKG changes that we look for to see if someone is having a heart attack. And then his EKG changed, and this kind of upsloping like this jump up like that, is a clear indication of a heart attack. He had an unremarkable chest X-ray, and his initial blood work showed his cardiac enzymes. Blood work looking for a heart attack, the cardiac enzyme levels are measured, were mildly elevated, but the EKG and his symptoms were very convincing that he had actually presented to the emergency room with a heart attack, with an ongoing heart attack. A very specific type called an ST elevation myocardial infarction. These are his heart cath films. He was rushed quickly to the heart cath lab, and We took pictures of his coronary arteries. We were suspicious it was on the left side of the heart based on the EKG. This first picture on your left is of
Dr. Kumkumian, I'm sorry to interrupt. Are you moving your slides because we cannot see them being moved?
Oh, you cannot.
No, I'm so sorry to interrupt.
No, thank you for interrupting. So you're not seeing the slides move. Oh.
No.
Huh. I'll try to share again.
Okay. Thank you.
Yeah, of course. Thank you. You don't see the slides there?
Are they being shared?
Yeah.
No.
Do you want to see if you can pull them up from your screen? Because according to me, it's sharing.
Let me see here. Can you see it now?
I see what it is. No, I can't see them. You can see the slides?
I can see them now.
Oh, goodness. Maybe I need to stop sharing. Maybe that's my problem. Okay, I can see them now. Can you see the films?
Yeah.
Okay. Are you seeing an angiogram moving?
Yes.
Okay, good. So again, just to briefly say that the gentleman was 50 years old. He presented with evidence of a heart attack. So I think you're controlling my slides now. And the leftmost film is a picture of the right. Can you go back one? The leftmost picture is of the right coronary artery, which looked fine. And this picture on your right is of the left coronary system. The first artery coming down looks fine. And again, this is how we evaluate. You can go to the next slide. This is how we evaluate if there's a blockage and where the blockage is. I'll go back one if you could. Thank you. Back one image if you could. One slide, I mean. Yeah, there you go. If you could play that. And there you can see the artery stops in the middle, coming straight down. And that's the occlusion. That's the heart attack. And then if you look to the next picture on the right, you can see we passed a wire down and the artery starts to have good flow. And if you go to the next slide, there's us putting a balloon and stent in on the left slide. And then on the right, one of the final pictures showing reestablishment of flow through the coronary artery, therefore stopping the heart attack. So that's what we do when you come in with a heart attack, emergently, take you to the heart cath lab, take pictures such as this, an angiogram. And this gentleman, these are his specific pictures. You can go to the next slide. So again, it's best to prevent, but when an event occurs, and we'll talk a little bit about what a patient should do, a person should do if they're having chest pain. But when symptoms do occur, it's very important to get prompt help, and we'll talk more about that. That gentleman, the one we just described, did pretty well. He had minor injury to his heart muscle. was discharged from the hospital a few days later, and it's followed up in the office, and he's doing pretty well. He's going to start cardiac rehab, we think, in about 2 or 3 weeks. So just to give some background, cardiovascular disease is listed as the underlying cause of death for almost 1 million deaths in the United States, going back to 2021 when the most recent full statistics are available. In the world, there are over 19 million deaths related to cardiovascular disease. And of cardiovascular disease, coronary artery disease, heart attacks are the most common cause of death. Next slide, please. So there are approximately 800,000 heart attacks a year in the United States, and about 400 deaths per year, deaths from heart attacks. Heart attack is estimated to occur about every 40 seconds. And the average age for a male to have a heart attack is around 66 years of age, and women 72 years of age. There's a kind of a delay for heart disease in women, and we think it's from endogenous estrogen as a protective effect at younger ages. Next slide, please. In terms of symptoms, most heart attacks for both men and women occur with symptoms of some sort of chest discomfort. I think probably one of the mistakes that we as physicians and nurses make is we ask patients if they're having pain, and rarely do patients describe their discomfort as pain. They describe it as a fullness, a tightness, a pressure, a squeezing sensation, which occurs in the middle of the chest. Sometimes it can be confused for indigestion. Typically, symptoms related to a heart attack don't come and go in a few seconds or a minute. They tend to persist. Sometimes they persist and they won't go away until a heart attack is completed or patient gets help. Sometimes they can wax and wane, what we call stuttering discomfort, which means the artery is probably struggling to stay open but is almost completely closed. Often pain in the chest or discomfort in the chest will go to the arms. It can go to both arms, either arm, both, to the jaw, the neck, the back. Shortness of breath is often associated, but not always, with heart attack pain in the chest. Cold sweats, nausea, and lightheadedness are often associated. But a patient having a heart attack can have one or multiple parts of this syndrome, as an identifier for a heart attack. Next slide, please. So again, even for women, most common symptom is still chest discomfort and pain, but women more often than men anyway, experience non-chest pain symptoms: jaw pain, arm pain, shortness of breath, sudden severe fatigue, nausea, vomiting. So there is a difference, and with age, there's a difference. Older patients or older individuals having a heart attack have slightly different symptoms. The symptoms are described differently often. But again, chest discomfort, shortness of breath, sweaty, a cold sweat, jaw pain down the arms, those are things typically we think of as pain from a heart attack or from a heart episode that's leading to a heart attack. Next slide, please. So time is muscle. This is a kind of a famous saying in our field. For particular types of heart attack, the type that we just described, the gentleman with 50-year-old gentleman who had those EKG changes and had a blocked artery, that's called an ST elevation myocardial infarction. It's a very specific type. For that type of heart attack in particular, we call time is muscle, which means the quicker you get help, the more likely you are to preserve heart muscle function. And heart muscle function is everything. The more you preserve your heart muscle from injury, the more likely you are to have normal heart muscle strength, the more likely you are to survive and live a long life. Unfortunately, the majority of people having chest pain symptoms, suffering a heart attack, often drive themselves or have someone drive them to a hospital. This is a mistake, and it's a big mistake. If you or if someone with you or someone you know is having chest pain and there's true concern about it being severe and a heart attack, then calling 911 may be the most important thing you do. It has been estimated that about 1 in 300 patients or people suffering a heart attack transported by EMS, by paramedics, go into cardiac arrest on the way to the emergency room. So you can imagine if you're driving someone or someone's driving you and you have a cardiac arrest, you're not likely to survive that event. The likelihood to survive an out-of-hospital cardiac arrest is about 10%. So this goes back to the major point is, if you or someone is suffering chest symptoms or other symptoms that are concerning for a heart attack, calling 911 is the most important thing you'll do. Every 30 minutes saved, in other words, the quicker you get to help, significant improvement in survival. There's a correlation with significant improvement in survival and heart muscle function. And this slide is an old slide, but it still is apt. And you can see the longer you go out, looking at the x-axis, going from 0 to 1 to 3 to 6 to 12 to 24 hours, mortality goes significantly up the later one delays their care. Next slide, please. So what can you do when you're at home and you're having symptoms and you're concerned you're having a heart attack or your loved one or a friend? Number one is to take aspirin unless there's some contraindication, a severe allergy of some sort. And to chew aspirin if it's possible so that it gets absorbed quickly, and to take 4 baby aspirin or some equivalent to that is appropriate. Again, to call 911, not to drive oneself to the hospital or have someone drive you to the hospital. If a person has a history of a heart attack or heart disease and has nitroglycerin available, that's appropriate to consider. And if a patient or a person has a cardiac arrest, and there's a bystander performing prompt CPR, and if there's an AED available, having the AED available and using it are 2 critical steps. Next slide, please. So just to give a little background, coronary circulation can be confusing. People misunderstand what the coronary arteries are. These are the arteries that feed the heart muscle, not the chambers of the heart, but the heart muscle itself with blood, giving the heart muscle itself nutrients and oxygen. It's a vast network of arteries that become smaller and smaller with a venous or vein system that brings blood back. The first arteries that come off the heart go right back to the heart. These are the coronary arteries. Next slide, please. Just to give you some perspective, it's always hard to understand how small coronary arteries are. Most coronary arteries, the ones we visualize, are somewhere between 2.0 to 3.5 to 4 millimeters in diameter, like the tip of this pen insert. So very, very small. When we're working on the arteries, and the way you saw that on the angiogram, that's all magnified. But these are very small arteries, about 1/8 of an inch typically in size. Next slide, please. This is a depiction of the inside of a coronary artery. There are 3 layers. That inner layer you're seeing is called the endothelium, and there's a muscular layer and then an adventitial layer. The muscle layer, which is the next layer going left inside to outside, that's the layer that is responsible for constricting and dilating the arteries when necessary. That little red spot you see is an example of the beginning of injury, the very first steps of injury to the coronary artery. Now, when I say injury, I mean the beginning of plaque buildup. What's very interesting and also worrisome at the same time is that in autopsy samples in young men or women who have died in wars, the Korean, the Vietnam, and elsewhere, autopsies have shown the beginnings of plaque buildup in this fashion very early in life. So early intervention, early good health habits are very important. Next slide, please. The pathophysiology or the mechanism of a heart attack really is different than most people think. I think most people imagine that the arteries gradually over time get more and more narrow, more and more plaque builds up. But typically what really happens is that the lipid-rich plaque bursts and tears that and therefore causes clot to form and block the artery. I think the next slide will show that a little better. And again, if you go left to right in our pictures, you can see the beginning of plaque buildup. And when I say plaque buildup, what that means is that lipids and inflammatory cells like macrophages and the combination get under the lining, this thin underlining you saw on that previous slide, and that's the beginning of plaque buildup. And then over time, the middle slide, you can see a large bulge in the artery. And that's a formation of what's called a necrotic core with a cap. It's when that cap tears, and that's the picture most to the right, that the materials from inside this cap, the fat, the inflammatory cells, the macrophages, and other parts of that plaque get released. And when released into the bloodstream, right there, it's very procoagulant. In other words, platelets in the coagulation system clot right there. And that's what a heart attack is. It's not necessarily the artery becoming more and more blocked over time. It's the rupture of the plaque, tearing of this cap over the plaque that typically causes a heart attack like the one we saw in that gentleman. Next slide, please. So what are the risk factors, the most commonly known and commonly spoken of risk factors that increase a risk for coronary artery disease and for stroke and heart attack? Diabetes, obesity, hypertension, high cholesterol levels, tobacco use, and a family history of premature coronary artery disease. There are other risk factors as well, but this is kind of the bread and butter of risk. And it's very important, knowing this, that people monitor their blood pressure, their cholesterol levels, to stay active and exercise and keep their weight under control, and not to smoke and have good habits. This is important for everybody, but with family history, often like this gentleman whose grandfather died of a cardiac arrest at age 50 and he had a heart attack at age 50, family history is very compelling as a risk. Next slide, please. So prevention of coronary artery disease, if you look at this wheel, you see all the different spokes or areas that are important for heart health. Lipid levels, cholesterol, blood pressure, physical activity, diabetes, tobacco use, all these areas are important to monitor and treat when appropriate. Just some areas of interest. Over the past few years, there's been a change in thinking on the use of aspirin for prevention. For the most part, aspirin for prevention is no longer recommended. 5 years ago, that would have been different, but a few studies came out that showed use of aspirin for primary prevention to prevent a stroke or heart attack for most people is not appropriate. The risk is actually higher than the benefit. There are small niche patients that actually would benefit for aspirin to prevent, but for the most part, aspirin is no longer used for primary prevention. Now, if you've had a heart attack or stroke or stent or bypass surgery, blockages in your leg arteries, things like that, aspirin is very important. Next slide, please. This is the kind of the food pyramid that probably best describes a heart healthy nutritional lifestyle. With the most important foods that are good for your heart being at the bottom and the least good at the top. And this mimics, for the most part, the DASH and Mediterranean diets, which are the best studied diets, showing reduction in risk for future heart disease risk and stroke risk. And the diets are really focused on fish, very focused with whole grains, vegetables, fruits, legumes, beans, seeds, some nuts, olive oil, and move away really from refined carbs, carbohydrates, simple sugars, processed foods, red meat, cheese, butter, all the good stuff. Next slide, please. Just wanted to give you, this is called the Predimed trial, which is probably the only or one of the only trials that showed clearly reduction in cardiovascular events, stroke, heart attack, death from cardiac and cardiovascular issues. Patients taking a Mediterranean diet versus a control diet, which means a diet that's not Mediterranean. And there was about a 30% reduction in cardiovascular events, stroke, heart attack, and other similar events. So again, nutrition and diets, these are difficult studies to do. This is one of the probably best controlled trials that were completed. And there's a lot of observational data that supports the Mediterranean or DASH diets. Next slide, please. Sodium, increased sodium intake does correlate with increased cardiovascular death. And this applies very much to how sodium affects blood pressure. A reduction in sodium can improve blood pressure readings from anywhere from 4 to 10 millimeters of mercury if an individual has high blood pressure. Reducing sodium to below 2,400 milligrams or below 1,500 milligrams a day is an important step for better blood pressure control when hypertension is a concern. Next slide, please. About somewhere between 10 and 15% of people in the United States smoke. The most recent statistic was close to 12%, which is far down from the mid-20th century, where it was somewhere between 40 and 50% of adults smoked. Smokers on average lose about a decade of life. This is from cancer, various cancers, and also from cardiovascular death. Smoking increases inflammation. So what's inflammation? Inflammation is the process by which plaque builds up in the arteries, and that can lead to stroke and heart attack. It also causes platelets to not function well, therefore to clot more, increases clotting likelihood. Endothelial dysfunction, that's that inner lining of the artery that I showed you. That has a very important role, not only keeping things out and in that you want in the blood vessel, but also it releases different cytokines and chemokines, these different chemicals that protect the artery. So when you smoke, you cause dysfunction of that inner lining. Next slide, please. Exercise is a key component to heart health. The American Heart Association recommends between 2 and 3 hours per week of exercise, more vigorous than closer to 2 hours, less vigorous than closer to 3 hours, and some combination of aerobic and weight resistance is recommended. And exercise does a number of things. It's good, first of all, psychologically. It leads to weight reduction. It leads to reduce in blood pressure. It leads to improved glucose control for diabetics, reduction in total cholesterol and LDL, which is the bad cholesterol, and triglyceride levels. It increases the good cholesterol level. So there are lots of good effects from exercise. Next slide, please. So in summary, prevention of coronary artery disease is a lifelong pursuit. It includes a heart-healthy diet, Mediterranean type diet, DASH diet, exercise, regular exercise. It includes important vigilance on patients or individuals' blood pressure and cholesterol levels, smoking cessation, control of blood sugars of an individual's diabetic, and regular monitoring of these different risk factors. And if you or someone is suffering a heart attack, it is very important. 2 basic steps: aspirin and call 911. And I think that's it. Thank you very much for your time.
So now Megan's going to present a little bit more on exercise. Thank you, Dr. Kumkumian.
All right. Thank you. So yeah, I was going to talk about more in the general idea of preventing a heart attack, and some of it will be a little repetitive, but hopefully not too much. So I'll share my PowerPoint with you. Can everyone see that? Is it working for you guys?
I can see it.
Okay, perfect. Yeah, just generally talking about some things you can do on your own to prevent heart attacks. And so basically, AHA came out with something called Life's Essential 8. So I'm kind of going to go over those areas, which are some of the things that Kumkumian talked about. But as you mentioned, there are cardiovascular risk factors. So first thing is just knowing what your risk factors are and things that you can modify. And so their modifiable risk factors are going to be the high blood pressure, cholesterol, diabetes, obesity, sedentary lifestyle, smoking, and stress. And then obviously, as you mentioned, there are unmodifiable risk factors as far as your age and then family history, which does play a big factor. So physical activity, Here at Cardiac Rehab, we work with patients who have already had cardiac events, but we hope to help prevent people from having cardiac events in the future. And so, like you mentioned, that physical activity recommendation is going to be about 150 minutes per week of cardiovascular exercise. So that's going to be spread out between 3 to 5 days. So that could just be 30 minutes of exercise 5 days a week. Would get you to that goal. And it doesn't have to be anything intense or high intensity. If you do high intensity exercise, you can actually do a little bit less of it per week to get the same benefits. But just going for an intentional walk would reach those goals. And depending on where your kind of physical abilities are, you don't even have to do 30 minutes straight to get those benefits. You can break them up throughout the day. So even 3 10-minute walks would help kind of reach those goals, and you can add in over time. You can build that up to reach a total 30 minutes in a day, and you would still get similar benefits. And then over time, you just want to listen to your body, kind of figure out what you can do. And as you increase your exercise and be able to do more and more, you just want to pay attention to how you're feeling and give your body rest as needed. If you feel tired one day, it's okay. Don't worry about don't push through unusual feelings or symptoms. And then your heart is a muscle. So similar to other muscles in their body, your heart is also a muscle. So doing that cardiovascular exercise, benefits your heart by kind of doing that repetitive motion to build that heart strength up over time. And then in general, just starting with a goal of moving more and sitting less is kind of just the easiest way to get started. So if you're sit at a desk all day, just kind of getting up every hour and walking around for a few minutes can kind of keep that cardio moving throughout the day, not just sitting down and just trying to get started with something small. And then to keep motivated, kind of setting goals for yourself, making a regular routine that you can follow, having accountability people, they can all kind of help get you continuing to exercise on a regular basis. And then also, once you kind of have a cardiovascular routine built, then you want to add in some resistance training as well to also build up the other muscles as well, keep you stronger, keep your body physically able to do those cardiovascular exercises. And then nutrition. So some big factors with cardiovascular disease is going to be weight management and diabetes management. And as Dr. Kumkumian mentioned, the DASH diet and Mediterranean diet are kind of the two staples right now for cardiovascular health. And so they're pretty straightforward. It's nothing super complicated. You don't have to overthink it. It's just focusing more on low sodium, vegetables, eating more fruits and whole grains. Those lean proteins, fish and seafood are going to help kind of get you moving in the right direction with your nutrition. And then primarily just cooking at home, trying to limit the amount of food you're eating out, limiting the processed food you're eating, and then watching like your calories and your portion control are both going to help benefit that as well. And then limiting those added sugars, the refined carbs, limiting alcohol and red and processed meat, fully fat dairy, all those kind of things. It doesn't mean you can't ever have any of it. It just is recommended that you limit those, save them for special occasions, make them more kind of a special thing versus a daily habit. And then avoiding the trans fat and partially hydrogenated oils as well. And then another area you can focus on is learning how to read a nutrition label. So a lot of time if you meet with a nutritionist or dietitian, they're going to help kind of show you what the areas of the nutrition label mean, kind of give you direction on what you should be looking for, and how you can kind of know what to do when you're going to the grocery store and buying foods. And then diabetes. So type 2 diabetes is when the glucose builds up in the blood, and instead of going to cells, it's causes your blood glucose levels to raise. And so kind of knowing your numbers, getting blood work done, and when you have your doctor's visits, kind of paying attention to those areas, so you can help control diabetes if you already have diabetes. And then the nutrition factor is really going to help manage that as well. So nutrition and diet and weight management are going to help work in that area. to help either prevent diabetes or control diabetes if you already have it. So stress management. So stress, I feel like it's underestimated in the amount of effect it has on your cardiovascular health. And that's going to involve your sleep as well. So it's hard to really, sleeping habits are easier said than done. It's hard to really control that sometimes, but you want to aim for 7 to 9 hours of sleep. Too little or too much sleep can really have an effect on you. Sleep is vital for the healing process in your body. It helps to repair cells, tissues, blood vessels, and then it also helps to strengthen your immune system and give better brain function. And so you want to try and find ways that you can focus on sleep health, whether that's creating habits at night that can be dim lighting, reading versus being on your phone before bed, turning off all electronics now 30 minutes to an hour before bed can all kind of help in those areas. And I know Dr. Kumkumian mentioned, talked about smoking, but smoking is the most preventable cause of death in the US. It damages your circulatory system, increases your risk of multiple different types of diseases. And so it's not an easy thing to quit, but it is one of the easiest ways to prevent diseases by smoking cessation. And then finding ways to fight stress. Stress is kind of a big struggle in our world today. It's not, it's something that's just ingrained in our work life, our home lives. It's hard to avoid, but there are ways that you can fight stress through healthy habits. And a big one is just going to be talking with people, whether you talking with friends, talking with family members, finding a professional that you can meet with and that's kind of outside of that circle, someone different. And then doing physical activity is going to have a big benefit on stress levels, learning breathing exercises, and then getting time outdoors, doing active things outside, getting some sunlight, are all going to help towards fighting the stressful things in your life. And making that a priority is important in your day-to-day life. And then blood pressure, cholesterol. This is, something you just want to pay attention to your numbers, know what your blood pressure is, whether you are getting checked when you're going to your doctors, or if you have a blood pressure cuff at home and watching those trends over time. You want to just kind of keep track of, one, high blood pressure isn't anything to worry about. But if you're starting to notice that it's trending upwards or you're having consistently high blood pressures, then those are things that you want to be aware of. And so you can talk with your professional about that, talk to your doctor, and they can work with you on medication, work with you on habits that you can do to help prevent high blood pressure or improve those numbers. But high blood pressure should be diagnosed by a professional. So make sure you're talking with your doctor about those things. Your systolic, the upper number, is the pressure of the arteries when the heart contracts. And the diastolic low number is the pressure in the heart is at rest between beats. And so, generally you want your blood pressure to be below 130 over 90 is the ultimate goal. A normal blood pressure is going to be considered less than 120 over 80, which is kind of ideal. And then the HDL or the cholesterol numbers. So your HDL is going to be the healthy, good cholesterol, and it helps keeping the LDL from sticking to the artery walls. And so creating habits through nutrition and exercise can both actually help benefit both those numbers and improve those numbers. And so you can kind of generally, the physical activity and diet are really going to help increase and improve everything else that's going to benefit your heart health. And then working with your doctor is very important, making sure that you're communicating with them, letting them know how you're feeling, letting them know what's working, what's not. And you will help work with you on medications, and being compliant with your medication is also very important for just continuous health over time. And that is all I have.
Thank you both. I appreciate it. I appreciate this presentations. We do have a few questions, and I just want to remind everyone that's viewing today that they can put their questions in the Q&A box on the bottom of the screen. The first question is, if my family has a strong history of heart disease, what should I do, or when should I seek medical care to do to medical care do I need to see a cardiologist at specific time frame if no symptoms? Like if I don't have a family history of heart disease, do I need to see a cardiologist?
So if you have a family history of premature coronary artery disease, which would mean a first degree relative, a man 55 under the age of 55 or a woman 65, like your mother or father, brother, sister, then yeah, I mean, I think one would want to be even more vigilant than typically in terms of monitoring your risk factors, getting evaluated. Usually the internist is a good guide to when that should happen. Typically that would not happen in your 20s and 30s, other than managing blood pressure and cholesterol and encouraging good lifestyle through your physician. But depending on when a family member had heart issues, that in their 40s or 50s, then you may be referred to a cardiologist for testing. It could be just looking at an EKG, talking, maybe getting what's called a calcium CAT scan score, things of that nature. But it depends on the specifics.
And thank you, Dr. Kumkumian. And so if someone goes in for their primary care physician and they take the labs and their labs are their cholesterol is high, would that mean that the doctor would, I mean, I suppose it's a conversation between the patient and doctor, but when would it be appropriate for the patient to go on medication for high cholesterol or high blood pressure? Is it a consistent measure of a high labs, or is it like one time and then poof, you're on medication?
I mean, typically it's supposed to be a thoughtful process. So it would depend on a person's other risk factors, their age, their lifestyle, um, and the levels of the cholesterol levels. So we use, hopefully good judgment cardiologists and internists. We also have tools that measure your risk based on your risk factors, your cholesterol levels that help guide us. Not everybody who has high cholesterol needs to be on a cholesterol lowering medication. Some do. And again, it would depend on the specifics. If your LDL or bad cholesterol level is very high, 180, 190, those levels, there are very few exceptions to the rule that a cholesterol lowering medication would be very important, because that typically correlates with familial hyperlipidemia, which has a much higher risk for early heart disease. So again, it depends on the specifics, but it's not a reflex, and it depends on your specific risk factors, age, and levels.
Okay. That's good to know. Do you recommend taking Q10 with a statin, and if so, what dose?
I guess that's for me. So coenzyme Q10 is used with statins because statins can deplete that particular element. It is not typically one is prescribed and the other one is recommended at the same time. There are actually no good trials that show benefit of coenzyme Q10 related to statin use in terms of symptom side effects. But anecdotally, most of us have used coenzyme Q10 to reduce some of the side effects on lipid-lowering medications like statins, and find that it has worked for many patients. So only if I think patients have developed side effects like muscle aching or cramps do we typically recommend starting it. Because remember that probably about 90% of people who take a statin don't have side effects.
And what would the side effects be?
So side effects of statins occur, again, about 1 out of every 10 patients. That's an estimate. It would be muscle aching, muscle fatigue, leg cramps, muscle cramps, a change, and it's usually muscle related. It's very rare to have any issues with your liver enzymes. Those are checked after you start on a statin. And statin is the most commonly used medication for lipid lowering because the data is so good. So that's the main side effect, is muscle aching. It's not permanent. It's not an injury. Typically, when one stops the medication, it can go away. And some statins will cause it in one patient, but another statin may not cause it in that patient. So often we change statins if that's the case.
Okay. Okay. Well, I'm sorry, Dr. Kumkumian. One last question related to calcium score. So my brother has a high calcium score, so I tested and it is also high. I am healthy and active. Any follow-up needed?
I guess it depends on how high, right? I mean, a very high calcium score is considered more than 300 or 400. That's one measure. And then percentile wise, because young people can have lower calcium score, but by percentile, comparing to gender and age, it could be as a percentile high. So it would depend on how high, what are the other risk factors. So many people who have a very high calcium score, we are more aggressive about recommending lipid lowering protocols, cholesterol medicine, for example. And often we'll do a stress test to evaluate whether that high calcium score correlates with any like severe blockages. Because a high calcium score does not mean you have a severe blockage. It means that there's a lot of calcium in the coronary arteries, which means there's a lot of plaque. That doesn't necessarily mean there's severe narrowing, though. So a stress test would evaluate that. So again, it's the particulars. How high is the score? What is your age? What are the other risk factors? And again, we use various tools and algorithms to kind of help us decide who needs to be on a statin, who doesn't, who needs to be more aggressively managed and monitored.
Thank you. Meghan, so if someone needs to get on an exercise program, they want to, get healthy and prevent heart disease, what is the best way to get started?
So the best way is just going to be finding what works best for you as far as an exercise routine. It doesn't have to be very complicated, specific exercise. Like I mentioned, you can just get started with walking. And then if you really want more specifics with a routine, getting in a gym, things like that, you can always get a personal trainer. And there are specific trainers that work with cardiovascular patients or have a certification in that. But in general, just finding someone who can give you general direction in exercise tolerance and building up exercise over time. But listening to your body, knowing kind of what it feels too difficult, if it starts to feel too challenging, cutting back and just gradually building up as you can tolerate more exercise, being intentional with your exercise. So instead of just walking casually with your dog while they're stopping every 2 minutes to smell things, making your walk intentional, making sure you're actually getting that heart rate up with your exercise instead of just a casual stroll.
Good, thank you. Dr. Kumkumian, here's another question for you. The increased use of medical cannabis for pain. I hear there are interactions with the statin Lipitor. Why is this? And are there more compatible statins? How does medical cannabis affect cardiovascular health?
I don't know the mechanism for that interaction, to be honest with you, but I've heard of the interaction. Interactions with statins have to be taken very seriously. There are other non-statin lipid-lowering agents that probably wouldn't have an interaction. There are injectables called the PCSK9 inhibitors that one can take every 2 weeks, and there's other pill medications. The other medications are not as vigorously assessed for improving outcomes, but still very good. So that's another option if the medical cannabis is really important. Now, are we talking about smoking, the medical cannabis, because that has its negative effects versus other forms. So there's pluses and minuses, but I don't know the mechanism myself, but have heard of the interaction. And if the medical cannabis is absolutely necessary, then other forms of lipid lowering medications can be considered.
Thank you. I just wanted to ask our audience if there were any additional questions for our speakers today. I also want to just do a plug for our wellness classes at Suburban Hospital and over Zoom. We have many classes. Specifically, we have freedom from smoking, smoking cessation. We have our senior shape classes. We have our yoga from the heart classes. These are both in person and virtual. So if you are interested, if you don't already know, please check them out on our events page. So sorry, I just have to do a shameless plug. So I apologize. So if there are any questions, please put them in the Q&A box. But I wanted to also mention to our audience today that we will be sharing the recording of today's presentation as well. So you'll get that as well in the coming days. Next question: how do you assess and treat someone who has gone through transgender surgery or transition?
For cardiovascular risk, you mean?
I assume so, yes.
I don't think that there would be any difference. I mean, you're still concerned about risk factors. I guess if one is affecting endogenous estrogen levels in that treatment, then that would have to be taken into account because we know that endogenous estrogens are very protective. So if that's taken away, then earlier heart disease risk would go up. And other hormone treatments could affect testosterone, for example, issues related to blood pressure and cholesterol levels. But I think one would manage in the same way, monitoring closely lipid levels, blood pressure, which can be affected by some of these hormonal changes. But maybe one would be more vigilant about it.
Okay, good. That's a good question because I did not even think about it. Like, but thank you. Are there any other questions out there? No. All right. Well, thank you, Dr. Kumkumian. Thank you so much, Meghan, for being here today. And I also wanted to thank our marketing department, Annalisa and Sonatus and Karen Carlson and Becky Kane, because they were behind the scenes on this webinar as well. So I just want to give them a special thank you. And thank you again, and have a happy Valentine's Day. It's all about taking care of your heart and also taking care of, appreciation of yourself and loved ones. So thank you very much, and have a wonderful rest of your day. Bye, everyone.
Thank you for organizing it. Thank you.
My pleasure. Bye.